Pleasure to be back for one more talk. And as promised, so we're going to talk about the endotheliopathy of trauma. What does it mean for us, and obviously what does it mean for our patients? I have no conflicts to report. Real quick, an overview. So we're going to talk real quickly because I had some slides on the last talk about changes in trauma resuscitation over the last 1 to 2 decades. What is endotheliopathy? This is sort of a new buzzword that maybe you're less familiar with, maybe you are. And then look at relatively quickly some PAMPer secondary analysis, not from a clinical standpoint, from some biomarker measurement standpoints, cytokines and endothelial cell markers, and what they may be showing and how they relate to the endotheliopathy of trauma. And maybe talk about some clinical implications or intervention targets relatively quickly where we can intervene in the future and how this work may help. Again, I showed this slide before. Hemorrhage following traumatic injury is the second leading cause of death of why people die following traumatic injury. First is a traumatic brain injury, but this is what we try to prevent, minimize, and control with a clamp, and or once you get control of the bleeding, you deal with them in the ICU. Traumatic brain injury, the number one cause, which is very difficult. We believe that once someone has traumatic brain injury, there's not a whole lot to do, but there may be some ways to intervene early that may have some survival benefits that we talked about in the pre-hospital setting, multiple talks previously. So hemorrhagic shock in the endothelium. We all know that when patients come in and they're hypotensive, the length, the depth, how high their lactate is, their pH, and these are laboratory evaluations of their extremes of shock or how severe their shock was. And shock we use as a term, but hemorrhagic shock is related to the endothelium. And this has been known, the blood vessels, the cells that line your endothelium throughout your entire body is an organ system in and of itself. And we've known that they have the capability to release inflammatory markers, and they're keeping them happy is important, and shock does not keep them happy. It results in what we call a systemic response. And these disturbances, when you affect the endothelium, they result in coagulation abnormalities. In other words, your coagulation system, which is run by the endothelial surface, where clot can occur, is dysfunctional. Similarly, it releases inflammation. And these processes and this degradation of the endothelial cell barrier results in leaky endothelium, and that can result in pulmonary dysfunction based upon this CAT scan and this chest x-ray, the old historic ARDS, which we've really seen reduction as we've gotten away from crystalloid, but it still happens, and the requirement for vasopressors and inotropes when the body sort of shuts down and doesn't mount its own vasomotor tone, and we have to assist it. And these are the things that we deal with in the ICU, the manifestations of shock. And this leads to multiple organ failure, which is why, in the ICU, and I think this is why all these talks are very similar, the liver, the bowel, CNS, and what keeps people in the ICU, multi-system organ dysfunction and or failure. And the lungs, whether it be lungs, the abdominal cavity, or vasopressor requirements that keep you in the ICU. And someone may not require an operation. Someone may have significant injuries, femur fractures, and seatbelt sign with a cervical fracture, but they can go into ARDS. They can go into and be in prolonged ICU stays from what we call possibly these manifestations of shock, which we're going to begin to term endotheliopathy of trauma. So the historic trauma resuscitation, I showed a slide similar to this. 15 years ago, the patients received pre-hospital crystalloid. They come to the emergency department. They get crystalloid. They go to the OR. They might start getting some blood products early on, and they start bleeding from their eyeballs and their IV sites. And then maybe we give a little plasma, a little platelets. That has changed and how we would do it. We're starting to give whole blood components or one-to-one-to-one resuscitation very early and even intervening in the pre-hospital setting. But historically, this 2 units of crystalloid and the crystalloid dependence that we used to provide patients led to severe endothelial cell leakage and leaky capillaries. As we talked about, there was concern for popping the clot early on, and it led to this excessive crystalloid resuscitation led to many problems: a severe hyperchloremic acidosis, dilutional coagulopathy, hypothermia, and a whole list. Now, hemostatic resuscitation, which changed sort of, again, 15 or so years ago, and we started focusing on bringing what we call, as best we can, whole blood, all the components one-to-one-to-one together, and give this early. They started to show benefit once in the hospital. What's the randomized clinical controlled evidence of one-to-one-to-one providing benefit? That's the PAMPer trial, which was done and led by the Houston group under Dr. John Holcomb, and it showed one-to-one-to-one, and they compared it to one-to-one-to-two in a sense, which those things are very, very close, but a little less plasma and a little more plasma in your early resuscitation in the hospital. Now, this trial was not showed no statistical difference between these two curves, and this is 24-hour mortality and 30-day mortality. But if you were a patient or a loved one that was injured, I am sorry, this curve, this lower curve, is lower than this sort of tan curve. There's a separation between these curves. It's the hazard, the confidence intervals overlap, and there's no statistical difference. So in a journal like JAMA, you're not able to say that there's a statistical difference, but there are differences, and I would want my loved one to get one-to-one-to-one as compared to one-to-one-to-two. It did show that it reduced death from exsanguination, so focusing early on bringing one-to-one-to-one as close as you can to whole blood suggests a benefit. And most trauma centers continue to use master transfusion protocols or starting these processes in the emergency department very early. So the mechanism of hemostatic resuscitation benefit. How does one-to-one-to-one in the hospital benefit us? Well, certainly we presume it's helping with hemorrhage control. By bringing plasma and platelets with red cells together, we start to maintain your coagulation system, preventing traumatic induced coagulopathy. And there's thoughts that it protects the endothelium, which is what we're going to get into, which is really when your endothelium is not protected, that's the endotheliopathy of trauma. It also releases inflammation and the barrier integrity, which leads to ARDS, and overall body edema, and all the other effects of edema in our multi-system organ failure type of patients. So the endothelium, like I said, it's a very vast network of cells that lines all the blood vessels down to the capillary level. And it's a very wide surface area, similar to the blood vessel system. And we probably have not given it much attention as we should have. So the endothelium, this is a little schema of it, and there's some proteins that are protecting it, and they have these proteoglycan molecules that helps protect the endothelium, and they're markers of endothelial cell health. And so when these are there, some of these polysaccharide molecules, proteoglycan complexes, this is a marker of a healthy endothelium. But when the endotheliopathy of trauma, one of those glycocalyx constituents on the endothelium is called syndicin 1. And it's been shown that syndicin 1 is a quantitative marker for the endotheliopathy of trauma. And we're just going to, endotheliopathy is a buzzword. We're going to call it the manifestations of shock. But it's just a term to understand that the endothelium may be an organ system in and of itself, and it has effects. And preventing the manifestations of shock that lead to multi-system organ failure, ICU care, if you survive and get off the operating table, that's where this buzz term, endotheliopathy, is coming from. So So if you look again on the endothelium, there is cytokine 1 lies, again, it's one of these proteoglycans that are on the endothelium, and we have it right now on our endothelial cells. But if your endothelium gets sick, this cytokine 1 gets released. And it can be free-floating in the blood, and you can measure it, and you can monitor it. It's actually used in sort of signaling between the extracellular matrix and the plasma membrane here, and it has important functions. And when endothelium cells get sick, it gets released and shed. And this is really the endotheliopathy of trauma. If you can think the endothelium as an organ system, it really, when it gets sick, it causes three things. Number one, it causes inflammation. It results in an inflammatory cytokine cascade that has manifestations that lead to systemic problems, organ dysfunction, and everything that keeps us in the ICU. It also results in coagulation disturbances because the endothelium is where we continue to want to promote blood flow and not create a clot unless there's a hole in the vessel. And so we want to maintain a normal coagulation system, perfuse things that need to be perfused and clot things that want to clot. We want those functions to be well regulated. And we believe hemorrhagic shock in the polytrauma patient results in inflammation and coagulation abnormalities, all manifestations that we see in trauma. The typical trauma patient, when they come in, they're hypocoagulable, they're not making clot. About 48 hours after, 24 to 48 hours after you obtain hemostasis and they're in the ICU, then they become hypercoagulable, and we deal with DVTs and pulmonary embolus and all the other complications. And so the endotheliopathy, in a sense, is dealing with the manifestations of shock and how it affects the endothelium. And cytokine 1, which is right here, is released when proportional to the magnitude of shock. Okay? And then when you have this endothelial cell injury, you get fluid coming in where it shouldn't be, and the integrity of the typical endothelium is lost, and you get leaky lungs, you get fluid-filled lungs, you get fluid-filled organ systems, and the manifestations of multisystem organ failure. Again, barrier function of the glycocalyx, which is what cytokine 1 consists of. It protects these spaces between the endothelium and prevents leakage and fluid from going in. If you start to injure this, you can imagine that this barrier function is diminished and you get leaky capillaries and manifestations of resulting from hemorrhagic shock. Capillaries in your capillary bed, you're leaking again. This is multisystem organ failure in a comic form. So plasma and endotheliopathy, I know I keep using this word, but what do we know regarding plasma? It's been shown in laboratory animals in a relatively good science that something in plasma, something magical, something microvesicles, DNA particle, microparticles, something in plasma that's given to an animal or in a human presumptively, it's thought to benefit or protect the endothelium. And it's persistently been shown in laboratory animals, and that's where the research currently stands. As of in 2019, this is mostly done in animals, and it shows if you give plasma, it prevents the manifestations of shock. Not because it reduces blood loss, but it protects it. It calms the endothelium. It protects the endothelium. It makes it help restore its function and its barrier function, and it improves outcome, at least in a rat thus far. And this is just one of the basic science studies. It reduced permeability. It's good to get freeze-dried plasma or lyophilized plasma, FFP or LP, and it reduces significantly these green and purple bars, significantly less endothelial cell leakage at the endothelial cell level. Now, that's sort of the background, endotheliopathy of trauma, which is really what are the manifestations that your body gives you following hemorrhagic shock. Okay, we'll talk about the PAMPer really quick. 10% mortality benefit if you give pre-hospital plasma. There's an early separation at 24 hours, or right around 3 hours. The survival curves start to separate very early at 3-hour time point, and statistically significant at 24 hours. And I've already shown you this 30-day mortality, and I won't dwell anymore on this. I've already showed you the unexpected survivors. I love this figure, that there seems to be a ton of these black squares and the extremes of injury severity in the upper right-hand corner of this that suggests maybe that's where the plasma is having its benefit. These patients wouldn't otherwise survive without plasma. Oops. So where the plasma single was, I talked about last time. It's in the severely injured. It's in the blunt injured patient. It's in those with the severest of shock, the lowest blood pressure in the pre-hospital setting. They have with moderate transfusion requirements, and in the polytrauma patient that includes TBI. And I would suggest that traumatic endotheliopathy has this new term. In other words, early plasma particularly may prevent the manifestations of this endothelial cell injury, or the endotheliopathy of trauma. It's also been shown that in traumatic brain injury, similarly, that the syndicin-1 is also released, an isolated traumatic brain injury. And so there's blood vessels in the brain, similarly, just as there is in the rest of the body. And endothelium may be very important regarding a recovery and in traumatic brain injury. So I just wanted to quickly talk about some mechanistic analysis that we did on the PAMPer study. This PAMPer study, we gave pre-hospital plasma, and we resulted in some improved clinical outcomes, but we have no clue on how it worked. And that's what this sort of some of these studies or measurements were arrival. We got early blood sampling upon arrival, typically within the first 1 to 2 hours, depending on how sick they were. We got it at 24 hours, and we got it at 72 hours. We did a vast cytokine panel with 23 cytokine measurements on any patient that we were able to sample. We sampled like about 370 of the 501 patients. There is a sampling bias because the patients that were the sickest, that were on the verge of death, there was no time to sample, and the patients that didn't get sampled, they had a very high mortality, about 70% all died within 1 to 2 hours. These are the sickest of the sickest, and so we weren't able to get those. So some of these results are lacking those, the sickest ones, because there wasn't time to get sampling. Clinical care was more important than sampling for research. But we've measured cytokine panels, 21 biomarkers via Luminex panel, and we looked at endothelial cell injury, which one of them is syndicin-1, which are a group of endothelial cell markers. And so importantly, syndicin-1 levels are highly correlated with, they're a manifestation of shock. And so similar, arrival systolic blood pressure, totally correlated in the PAMPer study cohort. If you have a lower systolic blood pressure, you have a higher syndicin-1 level. If you have a larger 24-hour blood transfusion requirement, thus you were sicker, you were more likely in hemorrhagic shock, you have higher syndicin-1 levels. If you have lactates, the ones that we were able to get sampling, lactate and syndicin-1 levels are totally correlated. Depending on the level, similar to the crystalloid volume that you required in the pre-hospital setting is totally proportional to the syndicin-1 levels that we found in our measurements. And similarly, injury severity score, as your injury severity increases, your risk of hemorrhagic shock, syndicin-1 is also proportional. Like it goes up and it correlates with all these markers. Now, so you're saying it's syndicin-1, it may be just another, like a lactate. We get a pH or a lactate, and you're like, we want to make sure it goes down in the ICU, and these patients are improving. And so it's just another laboratory measurement. Well, we'll talk a little bit about that. That's why I want to discuss this. So importantly, PAMPer and syndicin, there are no differences in arrival systolic blood pressure, 24-hour transfusion requirements, lactate, crystalloid volume, pre-hospital, or injury severity across the PAMPer patients. In the plasma arm and the standard of care arm, there are no differences in arrival blood pressure, 24-hour transfusion, lactate, crystalloid volume, or injury severity score. The groups were excellently randomized. The only difference is they got some plasma in between. So when we looked at the cytokines and plasmas across the two arms of the PAMPer trial, straight up comparison, there were no differences in cytokines or endothelial cell markers. It's two very broad curves of patients, some majorly injured, some minor injured, and when you compared them, straight up comparison, there were no statistical differences across any of the cytokines or any of the endothelial cell markers. So I was like bummed, like crap, that really, that sucked. But we started working with some of these cytokine measurements and endothelial cell markers. And first, we did some hierarchical clustering. This is done in Danielle Gruen, who is a T32 PhD in our group, used computer modeling and clustered these cytokines, how they hang out with each other, and was able to show that they clustered, or they organized into two primary groups. There was a cluster A and a cluster B. And we were like, oh, that's pretty cool. We'll see what this goes. And again, she took all the endothelial cell markers and the cytokines and showed that there's two clusters. One cluster had cluster A had a ISS of 18, and the cluster B had an ISS of 27. So this is some more severely injured, more likely blunt, and more severe head injury. And this was a more likely penetrating trauma and a lower overall ISS in these two clusters. And the cytokines and endothelial cell markers totally determined this. It was driven from the cytokine measurements and the endothelial cell markers. It broke it into these two groups. It demonstrated that these groups are different by clustering analysis. Well, interestingly, there was differences in the survival. Cluster A had a higher survival relative to cluster B. This cluster, as I told you, had higher injury severity, more likely blunt injured, worse head injury severity. And so there was differences in the mortality across the clusters. And so the inflammation and the endothelial cell markers separated them into two groups. That makes sense, and that's great. And then it sort of correlates that because we know where the signal is for plasma, that in cluster A, if this is looking at the plasma benefit, comparing standard of care and plasma, and these two clusters that were driven primarily from the mediators themselves, the measurements to clinical. There was no difference in cluster A in the response to plasma. These patients were less injured, were more likely injured via penetrating mechanism, and I told you in my last talk that there isn't a lot of signal in that. And then this group, cluster B, was more blunt injured with polytrauma, including TBI, and that plasma resulted in a survival benefit in cluster B. So this was also very interesting and very cool. And I was like, oh, the cytokines sort of predict the response to plasma. The cytokine and endothelial cell markers, how they lay in a big computerized hierarchical clustering model, and it suggests that it can pick those patients that are going to benefit from pre-hospital plasma. So we looked at the PCA drivers. This means the interaction amongst those measurements that we did, the cytokines and the endothelial cell markers, and we wanted to see what was driving the determination of whether they respond to plasma or not. What was the drivers of the variance? And so there were some cytokines that were important, including IL-6, IL-10, which are sort of known cytokines. And then there was a lot of the variance, a lot of the differences that were resulting in outcome differences from these endothelial cell markers. And so we wanted to look at this a little more. So we looked at whether you lived or died. This is real simple. This makes sense. And obviously, if you looked at some of the cytokines, such as IL-6, and then you looked at some of these endothelial cell markers, if you lived, the patients that lived had lower endothelial cell markers, and the patients that died had higher endothelial cell markers, and the reverse for some of the cytokine. And this makes sense. If you're real sick following hemorrhagic shock and or traumatic brain injury or polytrauma, if you have an exaggerated of some of these inflammatory cytokines and the endothelial cell markers are higher, you're more likely to live or die. And this made sense. Well, because of that, some of those measurements showed the higher injury severity. We started to look at some of our markers as we increased relative to injury severity score. And we started seeing some, this is a panel of a lot of the cytokines, and as you go up in your injury severity, there started to be some separation. If you can just look at, for example, that's IL-6. And that blue line happens to be the standard of care, and the plasma arm, which is the red arm. If you can see, you start to see the separation as injury severity increases, and you start seeing this theme in different endothelial cell and a couple of the cytokines. Syndicin 1, right here, and we're like, wow, that's something interesting. So we looked it up, looked at it a little closer, and we're like, As your injury severity increases, and we had some pretty severely injured patients, there seems to be this effect that the plasma arm, which is red here, there's a separation and a decrease in syndicin 1. And simultaneously in the standard of care, very well randomized trial. Standard care and plasma, these patients are identical. Couple differences in the overall trial. They were more likely to get crystalloid pre-hospital, and they were more likely to get a little blood in the pre-hospital setting because there was no plasma in the standard of care arm. But those are the only differences in the randomization. But despite that, there seems to be this separation, and using syndicin is just a big specific measurement in this case. And so we found, again, multiple cytokines, IL-6, MCP-1, where there's this separation. And in these endothelial cell markers, syndicin 1, again, it was consistent that in this blue line standard of care, it started going up as you went into your injury severity, and plasma was protective. So we looked at, we initially looked at the arrival cytokines and endothelial cell markers. We looked at the time 0. When they first come in the emergency department within the first 1 or 2 hours. We said, well, let's look at the 24 hours, where are these markers, if they're able to survive to then, where are these markers going? And so when we looked at 24 hours, we adjusted for differences in resuscitation, whether they went to the OR, we did a multivariate complex modeling, and we showed at 24 hours there's statistical differences in both inflammatory cytokines and in endothelial cell markers, and they all follow that in the plasma arm, the endothelial cell markers are lower, and the standard of care arm, the endothelial cell markers are higher. And the same thing with the inflammatory cytokines, they're lower in the plasma arm, and they're higher in the standard of care arm. And the anti-inflammatory cytokines, which is the protective cytokines, they're higher in the plasma arm, and they're lower in the standard of care. So it's just begins to provide the mechanism of maybe why pre-hospital plasma, which has been shown in animals to be very beneficial to the endothelium, maybe it's finally being shown in humans. And this may be the first study, to the best of my knowledge, it's in the submission process. Don't take any pictures as we speak. So where plasma signal is, it's in the severely injured, it's in the blunt injured, severe shock, moderate transfusion requirement, the polytrauma patient. And I would suggest that its benefit, or why it has this signal, is this traumatic endotheliopathy, that it's beginning to protect the endothelium. If you compare them straight up, you don't see any signal. All patients that we have samples on, if you compare them straight up, but if you start to look at 24 hours and you start to look at higher injury severity scores, which correlates with blood transfusion requirements and severity of shock, that it starts to show a difference, and that plasma is beneficial because of that. So in review, syndicin 1 levels are highly correlated, again, with arrival blood pressure, 24-hour transfusion requirement, lactate, and crystalloid volume. And in the PAMPer study, either at arrival or at 24 hours, there is no difference in the plasma arms across all these factors that are totally, that also go up as syndicin 1 levels go up. There's no difference in any of these with the plasma and standard of care arms with increasing ISS. But there is a difference in syndicin 1 as a marker and other endothelial cell markers at 24 hours. And we would suggest that this data at least begins to say that maybe plasma is mitigating the effects of endotheliopathy. This is a word that we made up to show the manifestations of hemorrhagic shock. We're protecting the endothelium, and this may be the underlying mechanism resulting in pre-hospital plasma survival. It was demonstrated again at differences in 24-hour endothelial cell injury primarily. So how would we intervene with this target? I would suggest that the model that we would use, injury, survival, good outcome, MOF, infection or death. Early intervention, as I told you about, is very important. So the ways to do it are to reduce the shock and protect the endothelium. Do this up front. This could be with resuscitation. And plasma may be one mechanism, but early resuscitation, whole blood transfusion, a lot of things to reduce shock and protect the endothelium. And the other way is to target the cascade that results from hemorrhagic shock and minimize the inflammation and the endothelial cell damage. I don't know whether we have these yet, but right now I'd say it would be plasma is the best way. The earlier you intervene, the better, and it provides a mechanism of maybe why this is working. Again, I want to thank all the people at my institution for their help for the PAMPer study and all the secondary analysis, and I'm happy to answer any questions.